the prayer told, we are moving on to another important topic, which is often not taught. And as doctors, we even do not know the basics of part LGBTQIA plus. So today's talk will be on the basics of LGBTQIA plus and the role of palliative care. So we have Dr. Samira with us. Dr. Samira is originally from India, and after a few years of practice in India, she went abroad. And presently, she is working as a specialty doctor in critical care medicine at the West Middlesex University Hospital, Chelsea, and the Westminster NHS Trust. And her areas of interest are critical care medicine, anesthesiology, postgraduate teaching, research, and transgender healthcare. Uh, she she's a team player, and she uh, says the purpose of a doctor's life is not served unless he or she doesn't apply his education to society's welfare. So that is in brief about Dr. Samira, and I would like to welcome Dr. Samira, and it's over to you, Dr. Samira.
Thank you, Sunil. It's good to be back um, with Pallium Indian palliative care talks. It's been a big hiatus that I have not had any interactions with palliative care community. Let me share my screen. Yep. All right. And the presentation. I hope I am audible and the screen is visible, the presentation.
Yes.
All right, fine. Let's start now. I'd been introduced already. Yes, there was a brief introduction about me, who I am. And that was me a decade more than decade ago, where I started my journey as a transgender person. It was a journey of self-recognition and followed by transition to the desired gender. I grew up as a middle class. I grew up in a middle class Indian Muslim family. Um, Started my medical education, became a doctor. All throughout this process of um, seeking or gaining the medical education on one end and battling up, choosing how my gender or establishing my gender identity. These two paths had always given me, created quite a lot of conflicts in and around me. Both the choices were difficult to balance. I somehow succeeded medical profession, the initial career pathway, and then made a choice of going ahead simultaneously with establishing my gender identity while working anesthesiologist. I found myself uniquely positioned while while being or working as a doctor and as well as a transgender person. create systems at the workplace which ensures transgender inclusiveness in terms of how their employment should be, or how a transitioning transgender employee should be taken care of at workplaces. I continued that learning while myself being transitioning to the process, um, and broaden my horizon. Started talking with other healthcare professionals as well, that how you should also be equally empathizing towards the LGBTIQ community and become part and parcel of inclusion and diversity. What are we going to do here? Why am I here? Why are you here on this session? We are going to talk about the basic terminologies, understanding what is meant by gender, what is meant by sex, and the other terminologies in and around it. Understand what is LGBTIQ community stands for, how they are discriminated, how the healthcare system discriminates them. I will share my personal lived experiences, and what are the community's palliative care needs, where we consider palliative care as one of the shared domain of healthcare system, which is at a larger level, and palliative care being a part of that larger healthcare domain. How and what way we should be fitting into, um, or become conducive for addressing the community's palliative care needs. As I said, um, the basics about what is sex and what is gender. Sex is nothing but what is there in between your thighs. So it essentially addresses or says the anatomical location or the anatomy of that individual, what you exactly see when a child is born on that child's body in between thighs. And based on that, based on the genital anatomy, at that moment, you say that human being is a man or male or a female. Sometimes it happens that obviously, anatomically, the anatomy is not clear. And then such human beings fall into intersex. Now, as I said that this I talked about anatomical variation when it is visible. Sometimes when it is obvious and visible that the anatomy is not fitting into very obvious male or female genital anatomy. Sometimes it does, but some intersex condition where there is chromosomes are different, hormones are different, although their external genitalia looks very similar to one particular sex, that is male sex or female sex. And that's the reason why intersex is now considered as a spectrum. Differences in sexual development, DSD, would be an appropriate terminology instead of saying it as intersex, but colloquially, for us to understand very easily, intersex is another sex condition as similar to male and female sex. While, on the other hand, gender has got absolutely different attributes. It's all related in cultural domain, how culturally based on the attitude, feelings, and behavior is attributed either to a male or a female gender. Okay. Or, and it also refers to individuals' innate sense of being a man or a woman or not fitting into anything or might be fitting into any other possibility, and then hence it is non-binary. So gender has got both extrinsic and intrinsic way how you perceive yourself as. Extrinsic, as I said, that how the gender is being culturally defined, culturally associated with, and intrinsically how you feel your gender, how that individual feel their gender as. What about gender identity and gender expression? As I said that the last word, identification, identity, that how the person's, that human being, that individual senses their gender as, perceives their gender as. It could be male, it could be female, it could be both by gender, or it could be none, agender, or simply do not want to associate with any gender or various possibilities. So that's why gender identities are myriads of possibilities. We all have our own rights to define our own gender identity. It's up to you how you establish your own gender identity as. While on the other side, how you express your gender is the way you express your gender is your gender expression. To give you a simplistic example, it's very common in society, women wearing trousers and t-shirts. Okay. So it doesn't mean that there's one way of them expressing their gender, which actually does not fit into how we expect it. Like typically the clothes are, as I described, a shirt and a trouser is depicted or designated or recognized as a costume for a male gender. But now, changing situations, scenarios, a woman, genetically born woman who identifies herself as woman, can express their gender in terms of a man by wearing shirt and trouser. So there are various ways and possibilities how a human being can express their gender, which is nowhere connected with what anatomy they have on their body. On the other hand, sexuality. Let's move from gender, gender identity, and expression to sex and sexuality. Sexuality meaning how we are attracted and how we choose our partners for mating. Again, the terminologies and the choices depend on, like, for example, somebody who's attracted to a man and identifies their gender as a man would be attraction towards men, identifies as a man would be gay. So that's that person's sexuality. Somebody who's identifying as themselves as a woman and attracted towards women would be having an orientation, sexual orientation as lesbian. There could be a possibility that they are attracted towards men and women. So their orientation, the sexual orientation, could be bisexual. It need not be that what somebody orients and what they behave should be same. Meaning, one behavior is choosing somebody as sexual partner could be different. So somebody's orientation, human sexuality has two components. As I said, orientation, how you orient in terms of your attraction towards which gender, against how you behave. Now, behavior has got huge cultural component depending upon the social restrictions or the personal choices. Social restrictions, you find many of the gay men being pushed out of family's compassion to choose woman as a sexual partner. So they force or need to have their behavior condition to choose woman as their sexual partner. But their identification in terms of having attraction towards men will be a gay man. So again, when we come up to a terminology, India being having its own rich culture, different states, different languages, and different cultures in their own dialects, they have their own terminologies. So, gay, bisexual, lesbian, these are all very, the English words which have been used for depicting orientations and behaviors in terms of different identities. But culturally, you have got Kothi, Ranga as the dialects or words which are used in Tamil language. Ranga, Maichia being in Andhra, Panti again in Tamil dialogue. So that's how different identities have got intersectionality with different cultures and dialects. It might be sounding very, very confusing, but the basic concept remains very same. We need to understand what every human being has a sex, which pertains to their anatomy. Every human being has right to have their gender and identification of gender. Every human being has human sexuality in terms of how they orient their attraction and how they express their or condition their behavior. And that is what constitutes their sexuality, which has got huge influence in terms of how society looks at that particular human being. So it's a social dimension to the sexuality. So to sum up in a very simplistic way, it's a spectrum, and that's why we say it as a rainbow. And since it's a minority, a coalition with the acronym LGBTQI. And very commonly, people say or mistake that T, transgender, because that's the most visible community in India. We say everybody as LGBT, okay? But that's not the same. LGBT is not equal to T or transgender, because T, transgender community, is visible. Everybody try to use the word LGBT towards these. So to sum up, LGB is in terms of how sexual orientation is, the choices are, and T is how the gender identification goes. So identity is in how you identify yourself. So it's within your skull, how you think. Attraction is how you attract towards the choice of gender you have. And sex, what I mean to say is absolute anatomy, what you have it, that human being has it on their body in between thighs, and how you want to express phenotypically, how you want society to look at you in different ways, how you present yourself in the society is the way you express your gender is gender expression. This is a global map. I could not get exact statistics to say that how many um, people of different, I mean, same sex or different sexual orientations exist all over the world. But this map says that or identifies that yes, sexualities exist, and there are few places where which are being criminalized, or at some places like those who are in blue and the blue shades of blue, where these are being culturally, socially, and legally being accepted. So it means that yes, people from LGBTIQ community is not a phenomena only in the Western population. It's there in India, it's there everywhere. People with different sexual orientation exist anywhere, everywhere. What about the Indian situation? There's no statistics as such uh, could be seen or could be read anywhere, but I could get few numbers out of the statistics, the study, the census being conducted by one of the social media platform, that is Planet Romeo, which is a, um kind of a LGBTIQ social platform where people can meet and interact with each other. The study conducted by them to just fetch the number that how many, what could be the number of people who identify themselves as LGB be present in India. And India is a huge country, even though the number 1.35 billion appears to be very small in comparison with the huge Indian population. Just imagine how much impact it has in terms of amount of uh, number of people as such exist in the world or within India. And that is what this census says, which was conducted after 2018, where homosexuality got decriminalized. Those who were there on this app voted, and thus we know that there exist 1.35 billion people who identify themselves as LGB. So they openly came out and participated in this study. The number is still, exact number is still not known. How many of Indians who are hidden, who would like to keep their sexuality hidden, private, do exist. What about transgender people? This is a census, 2011 census. Sorry, I don't know, or I'm not sure about whether there is any 2021 census data which has been collected for or depicting um, transgender population. Probably I need to research a little bit more on that. But contrasting features about 2011 census data shows that there are transgender people who are segregated at few selected places. Now we know that the states where there is a high density of people who identify themselves as transgender. Now, as I said, that transgender community, the one which is exclusively the Hijra community in India, and that is what was got counted as third gender population in this census, was found to be segregated in these states. But what about the other states? Why this heterogeneous depiction of census? Why few states have got so many transgender population, third gender population? Why Gujarat doesn't have? Does it mean that Gujarat doesn't have any transgender people? Kerala doesn't have any transgender people? Now, there could be a whole lot of intersectionality in this. Probably people from transgender communities from these states might be hidden, may not be able to come out, or do not simply want to associate with the third gender, or what you say Hijra community, because it is considered as cult. And this is what exactly I would like to say about it. Hijra community, they have their own cultural norms, a different society, an absolute different culture where they associate themselves in the form of non biological family. They label themselves as sisters, mother, daughters, guru, or chela. And that's how the social dynamics and interactions happen. But on the other hand, there are few transgender people, and more visibility is coming today thanks to media, which do not probably associated with this cultural sect and would be having their own independent social identities and openly living, not identifying with this cultural sect. They may not be identifying themselves as transgender at all. They would might identify themselves as a man or a woman. Currently, there is huge amount of legal reform which has happened very recently after 2019 transgender persons protections of right. You will see more and more transgender people becoming visible who fall into independent identification, self identifications, and visibility socially. What about healthcare discrimination? Transgender people, they feel they get discriminated very often. To say just a small example as my own personal living experience, while I was transitioning, I had to undergo laser treatment to do facial hair removal. This facility was available in one of the institution where I was working while I was being in India, in South India, in Pondicherry. I thought that, okay, this is the institution where on these corridors I proudly walked as doctor. Probably this institute will help me out. I was sitting on this desk, on this bench, waiting for this door to open for me so that I can go in and have my laser treatment done. After waiting for a 1 hour, a junior doctor came from this door and said it to me. Sorry, doctor, um, we will be charging you. You can have treatment, we'll be charging you. But I think the reason why my HOD would like to charge you and says that we don't want more people like you to come. Is that okay that you go ahead, pay the money, and then we'll start the treatment? Mind you, this is a government institution and the facility is supposed to be free for every individual. I decided that I will not look back and walk away from this institution. Why the healthcare discrimination happens? We'll come back to this slide again. I would like to give you few more examples. I think somewhere it is imbibed in us because we are not adequately aware about or having a good perception about the LGBTIQ community. One, I would say that it's just because the community is hidden, that's why we do not know. That's absolutely not correct. It's all related to knowledge gap about what is homosexuality and attitude towards homosexuality. So this is what was a simple study which was conducted in one of the states in India, where questions were asked to the medical students and interns about how much amount of knowledge they hold based on their medical education, what they had it up about homosexuality, and how would they approach if somebody know that this person is a homosexual or belongs to L, G, and B community or identifies as L, G, or B. Questionnaire outcome came as yes, definitely there was inadequacy of knowledge. Many of the time, many of people, many of students, they took neutral stance. Interestingly, female students showed quite a significant amount of positive attitudes towards understanding that people from community do exist and they are comfortable. Probably they were keen in or having a right attitude towards improving knowledge about the community. And this is what I would like to say. Because our medical curricula never ever taught us about what is homosexuality, what is gender identity. Whatever the existing knowledge was there was wrong or booked into, written into sexual perversions, and that's how it got stigmatized. Either it was the chapters were just over and the pages were just skipped, their teacher was not comfortable to talk about, and just because Hardly anything is asked in the exams, maybe one MCQ or not at all because it has never been read. We as medical students never bother to open and read those chapters. We had our own personal beliefs from social perception about the community, and that's the reason why our attitude was ill formed. We did not had any medical legal clarity about how and what way the rights of this community are, and that's the reason why we do not know how to behave with these clients. Since these are our barriers in getting knowledge, appropriate, adequate knowledge, changing our attitude, and actioning into our practice, we create barriers to our clients which come to us. This is what exactly I would like to express this out. Now, what are those issues? What are these stressors? Where all we need to understand that the people from LGBT community going to get hurdles from. Let's understand what is meant by heterosexism and gender norm. We live in families, okay? People from LGBT community also have got families, but the family dynamics may be absolutely different. Families are supposed to be a warm shelter, preventing them from all adversities which they could be facing during their childhood. But when the intersectionality comes about, their sexual identity or gender identity, the same family might become hostile against them, might force them to acquire the norms what family thinks for them. And that's the reason why some of the LGBT families might be having their own non biological component into it. I hope you remember just now, as I said, about Hijra community, and they acquire the non biological family norms where they might be calling their relations as brother, sister, daughter, or son, which may not be of their biological origins. And this is what is the social structure which we need to identify while we come across people from the community. Marriage equality still is a limbo in our country. You might be hearing more and more amount of news about what's happening about the marriage equality. Somebody comes and says, this person is my spouse, this person is my partner, rather than using the word, this person is my husband, this person is my wife. People from the community may not be sticking to those set social norms and terminologies. And that's the reason why I said when you define a strict, rigid role or as man and a woman, you bound yourself in terms of heterosexual terminologies which may not be applied to people from LGB communities. As I said it, heterosexism meaning assuming that all of your patients are heterosexual and that everyone has or is interested in having an opposite sex partner. So somebody says husband, you will immediately think about it. Oh, this person partner must be a man, or a not thinking beyond what the person who is sitting in front of you is a man and saying that I'm having a husband. So it's a gay couple. Assuming that all children have opposite sex parents, there are um, two women raising children, the lesbian couple raising children, gay couple raising their children, assuming all sexually active women need birth control, using language that presumes heterosexuality in others such as husband or wife instead of gender neutral language as partner or spouse, as I said it just now, and using forms that allow for acknowledgement of only marital status as opposed to relationship status. And this is what something which needs to slowly change. If these boundaries are rigid, we'll say that there's a quite a lot of heterosexism happening up. Microaggression. I gave you my example where it was outright discrimination which happened. Very openly, the discrimination happened. But yes, subtly also, softly also, discrimination can happen in terms of microaggression. Casually asking your colleague, asking someone, are you a man or a woman? Endorsing, pushing forward the heteronormative culture or language. Saying that bisexual people are confused people. Sometimes they think or choose a man, sometimes they think and choose as woman as their partner, thinking that okay, these are confused people. Defining your typicality and atypicality on LGBT community, assuming that all these people they want to engage in sex with anyone if bisexual or with anyone of the same gender. So associating and affiliating that basically LGBT people meaning or defined or orientation is towards how they have sex. That's absolutely a very, very narrow approach. And that's how it defines and creates an implicit bias in a healthcare professional's mind and going to affect your clinical relationship, and that's how your outcomes are going to be. This creates a huge negative impact on the community. And what you see is significantly high suicide rates within the community. To talk specifically about transgender people in society at different levels, when they get discriminated for various reasons, that induces a strong negative mental impact on their health because of lack of facilities to change their legal identity in terms of changing their IDs, families rejecting them, being rejected from the family and not having appropriate job as a survival strategy, opting out for begging and prostitution as a survival strategy, making them vulnerable for all odds of the society, facing up homelessness and increased risk landing up into increased sexual behavior, high risk sexual behavior, creating depression and high suicide rates. These are the some of the examples which community members they expressed when they came in contact with healthcare professionals at various situations. Read it out and you'll be astonished. Well, I'm not. This is how the people day in and day out still face because they do get discriminated out. One of the significant and strong baffling point struggle which the community face is conversion therapy. Now, conversion therapy meaning forcefully first not acknowledging that person's sexual identity, sexual orientation, or gender identity, and forcing them to change their orientation, meaning forcing a gay man by saying that we have a therapy for you so that we will cure your gayness and you can live a happy life with a woman. So we can convert you from a gay man to a straight man. This is how, this is what they condition and force people from the community, LGBT community, which has got a strong negative mental health impact on the community. As I said, that the strong prejudices which people hold about affirmative processes, very procedures, very specifically for transgender people. Here is an example. A transgender man would like to have the gender affirmative procedure of removing the uterus, but having a fixed heteronormative idea that uterus is supposed to be for motherhood, and how can you remove this uterus? If this is what the heteronormative ideas, heteronormative thinking, and prejudices we hold, the affirmative process of individual from transgender community is going to baffle. Yes, things are changing. What we should remember, what we should look into it, that we need not have to assume person's sexual orientation, person's gender identity, and person's sex characteristics based on how they express their gender. Things are changing. To say, as an example, that homosexuality was depathologized, was taken out from the medical textbook by WHO way back in 1992. If you still find it, that's not the truth. That's not the way it should be taken up. So, yes, recognition about sexual orientation and gender identity, not as a mental disease, is very clearly happened now. The current three legal reforms which happened in the last decade, the landmark Nalsa judgment, where the judiciary system gave or established the human right of making every individual to determine, that is, self determine their own gender. And if somebody is not allowing that thing to happen, to be considered as illegal and immoral. Homosexual relationships got decriminalized in 2018, and very recently, Transgender Persons Protection of Rights 2019 Act, where which was aimed exclusively towards transgender people in terms of improving their welfare and various other related matters. So, how a healthcare system should be? Healthcare system should be LGBTIQ inclusive. So, where all to touch upon? It has to touch upon every aspect of healthcare. The medical care being a small domain, one of the domain. Medical care in terms of medical health, you have people who are gay, lesbian, transgender. They are they are human beings. They will come to your clinic for diabetes, for cancer treatment, for any other thing. Definitely, you need to have them understood to include into it. Your healthcare should understand and acknowledge their unique needs. Transgender people, they have their unique need of where they undergo various affirmative procedures while establishing their genders. Medically, in terms of needing hormones, surgically, in terms of needing surgeries, or to take care of their mental health. The medico legal perspectives, as I said, that how legality currently is changed. Primary and preventive health, which will avoid them to come to the hospital at all, and what are the interdynamics related to that. Palliative care being one of the part of the larger domain of healthcare. We know you all have been learning through these modules the dimensions of palliative care and how and where to fit into it, the physical, social, spiritual, and psycho emotional dimensions intersecting the LGBTIQ communities at various levels. Might be getting discriminated, their griefs may not be supported, they have their own unique issues. Socially, they may not be acknowledged when it comes specifically to the end of care, end of life care, where they might get discriminated. What about religion and spirituality? We know that there are a few religious sects which consider homosexuality as crime. But when they come in seeking medical health care facility in these specific dimensions, are they going to get discriminated? What about our own prejudices, our own assumptions about their identities and orientations? These are all intersectionalities. We need to think about it. That's the beauty of palliative care. Anyone can be part and parcel of palliative care. It's not just you being a doctor. Palliative care community is basically everyone. All of us can be a torchbearer of palliative care. So all of us need to educate, need to learn what is the need of the LGBTIQ community, because we all have decided that we are going to deliver appropriate, adequate, culturally sound palliative care to the LGBT community. Very silent features or the principles which I have tabulated here. Now, each of these domains, each of these principles or best practices would be a separate session to discuss, which is out of my purview at this moment. But just to highlight you on this, let's take it one by one. Remember how your communication should be. As I said that gender is every individual's self-determination right. Anyone who wants to express themselves the way they are should be allowed. So when people from this community, whether they are expressing or not, you can address, you can talk, you can communicate and ask them rather than presuming and using very binary or fixed terminologies as sir or ma'am. This is just to give a very small example. This is something which is extremely confidential. Ask them, you are in these four closed walls. In these four closed walls, what happens between you and me, how I address you and me, is you need to tell, and you need to tell me out of these four walls, out of this clinic, how you want me to address yourself. That's how a very clear communication should start in the first go. We discussed briefly about family, the concept of biological and non biological families, and the terminologies we need to orient as in terms of partner, spouse, rather than saying husband, wife. A family can have, children can have two dads, children can have two moms, and you need not have to presume who is mother, who is father. Both can be mothers, both can be father. And that's how the new understanding which we need to have about family concepts. Many of the time, we forget that it's our client, it's our patient, which need to have an upper hand and need to have quite a lot of understanding about their dynamics in making the decisions, crucial decisions, very specifically in palliative care, in terms of end of life care, how the shared decision making needs to happen. It has to happen in a extremely respectable way where need to understand that you need to empower your client, and that's how that is going to improve their satisfaction. A simple example in transgender community, client coming to you for hormone treatment to start or change hormone treatment as a part and parcel of their gender affirmation. We might need to make the client aware about what are the pluses and minuses of that particular treatment modality, whether we should have that treatment started now or not, what are the stresses, what are the dynamics in terms of their pre-existing medical condition, and how it is going to get altered. Like, for example, hypertension might get severe by starting up estrogen therapy. There might be increased risk of cancer by starting up testosterone. These are all shared decision makings which we need to do it off by making your client aware about it. Mental health addressal. As I said that we charted out different stressors. At what stresses you are dealing, you are identifying your client in your care. It, yes, it can be during offering a palliative care choices also. What mental health support, unique mental health support the clients will need it, need to be taken into consideration. pain and symptom management. They say that specifically cancer treatment or HIV treatment, what could be their unique dynamics related to it, and how you are going to communicate with them. Last domain or principles, absolutely remembering that what are the legalities involved into it. Now, homosexuality is decriminalized. Now, transgender people, they have their own rights. Look into it. Are you, by not offering appropriate treatment, discriminating them? And when you say that the discrimination has happened, people might come and would like to seek legal help when they got discriminated in the healthcare system. Last, not the least, the spiritual beliefs what somebody has. As I said that religion, of course, it is different than spirituality. Somebody belonging to some religion is not equal to how they spiritually express their own gender. To say an example, for example, how and what way the death ritual happens of Hijra community. Just think about it. How many of us we are aware about the end rights of Hijra community? How much aware we are about how the spiritual dimensions of this community works out? That's what I would like to say at the end. If we don't know how this community lives, then how are we going to know how at the end this community dies? I leave it to you to chart it out. What are the needs? What you thought about it when such clients come, and you as palliative care professionals going to become palliative care professionals out of this teaching, how you intersect these dimensions, this physical, psycho-emotional, social and spiritual, against the LGBTIQ community. Thank you. Thank you so much.
Thank you, Dr. Sandra. And I think there were many points which we were not aware of, and even uh, the societal norms and things like that, calling husband, wife. So that's the usual thing that we for people usually talks about. But talking about partners is something which I think, even though it is not a new concept, but the importance is that you have now um, told us, and many other things which you have pointed out regarding the LGBTQI and transgender community. I'm sure many of us would not know about the points that you have told us, and this will help us to maybe as a first step to sensitive us regarding what can be done from our end, and maybe when we share more, then we will understand more issues and how to solve those issues. So I would like to open the session for discussion now. Stephia, please unmute everybody.
Yes, sir, they can unmute themselves.
Hello, Dr. Samira. Thank you very much for discussing this topic in a very open way that no one would like to talk about this issues in we often fail to discuss these things in our medical undergraduate curriculum as well as PG curriculum. As palliative care is also like very neglected topic. We often feel a kind of we refrain ourselves from discussing these things as well as we uh, kind of saying we present ourselves like we don't engage or encourage these discussions in a common forum. So in that way, it is very much very important topic that will be discussed in this in the palliative care scenario. Thank you very much for this very honest and uh, open-hearted approach towards this LGBT community. Thank you.
Yes, we have not learned Kavin during our medical curriculum, but then now the recent I don't know how many of you are actually aware about it. The recent judgment which happened by Madras High Court, where the NMC need to change the competencies which got introduced. The medical curriculum changed after 21 years. And when NMC is formed, the competencies were revived, introduced, and the curriculum got rolled in. With the old competencies, which had absolutely same terminologies been used, which were absolutely pathologizing and creating wrong impressions and concepts about homosexuality and transgenderism. Now, the Madras High Court gave the verdict that these things, these contents needs to be changed. That is one. And second, needs to be taught to the students. I was a part and parcel of that advocacy, but then after I mean, the judgment came in somewhere in 2020, and that was the time when I left India. So how much impact it has happened, and whether it has gone to the textbooks appropriately or not, and whether it is being taught or not to this generation, I'm not sure about it. Um, Having said that, probably I think the answer is still no. It is not been taught because just yesterday, day before yesterday, I attended international. I spoke in an international Royal College of Psychiatry's workshop. I happened to walk into the book exhibition, and picked up IPS, Indian Psychiatry Society's textbook. And out of interest, I opened the chapter on sexuality and disorders of sexuality, and I was shocked to read again the content about homosexuality is being taken out. I'm glad about it, but intersex, gender identity disorder, it's still the word used as a disorder. Then gender dysphoria and their own definitions about gender identity disorder or dysphoria being quoted, where nowhere the changed definitions of ICD-11 been included. So, and that's IPS undergraduate textbook. That is what was my project in 2016. I mean, where me and my colleagues studied and took out all these contents, and then uh, did an advocacy with IPS and various other healthcare professionals. But unfortunately, I think the change has got a huge amount of inertia, I guess. Let's see how it goes. Parul has raised hand. Yes.
Hi, Samira. Thank you so much for this enlightening session. Actually, I think this was the first time anyone taught us about the topic. Actually, what I believe in India, especially the cultural and the religious aspect, the values are so strong. It's very difficult to even to start the conversation because there is so much barrier, the culture barrier, and especially the religious barrier. How to begin this conversation among, especially when among the healthcare workers? I mean, how to start the conversation?
Okay. With whom you want to do conversation? A conversation from a person who belongs to the LGBT community and coming to you, or you want a person who is sitting along with the family and you would like to initiate. So give me a situation or scenario, and then we can
Situation,
take it forward.
yeah. Just to begin with this, the scenario of sitting along with the colleagues and to talk about it.
About give
About
me a situation or scenario if you could tell, then we can take it forward from there. It becomes very easy, difficult, rather than saying that um okay, somebody is Muslim, like for me, Muslim, and Islam does not accept homosexuality and it is considered as a crime or criminal activity.
Mm,
Somebody quoting about it, but when you come to a context, when you say that colleague, okay, you are at the workplace. So workplace has to be neutral. Workplace will not have a dimension that somebody getting discriminated in terms of somebody's religious belief. Each and every person has got its own belief. You have your rights not to believe that homosexuals need to be discriminated. And at the same time, person who holds strong Islamic belief has a right that homosexuals are criminal. But when we are coming in context at workplace, okay, the workplace is something which is very, very important and matter. And each one will have respect towards their own beliefs, and the context of conflicts will not come in here when you are working together. And that's how you need to make a very strong, rigid window. It's a simple thing. When we are starting this session, there were a few slides running, automatically running, where how and what way every person in this group should act or behave. So the ground rules have been laid. The same similar thing should happen when you're having conversations at your workplace in some certain situation and place. And that is what is called as safety. Safety at work culture, safety of not being getting hurt, not being getting discriminated in both ways. When it comes to an individual approach, okay, as I said that somebody is coming, walking in as a gay man, as a Muslim gay man, okay, and you as a Muslim woman, okay, holds a belief that a homosexual person is somebody who is a criminal or not a good person, okay. If you are not comfortable, you can go and tell it to your colleague, can you please handle this patient? I think I'm not comfortable. I'm really sorry. I apologize, but I think I probably will not would like to take care of this. Are these options available for that? If these options are available, you should go ahead with it. If you could totally eliminate it out, your religious biases when you are treating and taking care of the client, which should be ideally happening, that is what you need to do it of, not considering the person's sexual orientation at all in managing fever, in managing hypertension, in managing end of life care. That is how the strict boundaries you need to form into it. And that's how you need to understand the whole gamut of how not to do the discrimination.
Thank you so much.
Yeah.
Vijayasaharan?
Sairu has, oh, there are messages as well. Shall we?
Shripriya?
Sir, actually, we
Uh,
have the option to unmute. I'm not sure, like,
Vijayasaharan, you are
Yes,
already
yes, yes.
unmuted.
Good evening, ma'am. As recently passed out medico, even now we're not aware about the exact situation of the people of this community.
Sorry,
So,
who's speaking? Sorry, I'm not.
Vidyasagar, ma'am.
Okay, fine. Yeah.
I'm-
Yep. Yeah. Right.
What I want to know is that while I was in Chennai traveling in the in public places, I have seen many of them insulted this community peoples. I have literally seen the peoples of this community who are suffered by many of the peoples. Is there any options as a doctors or the not as a doctors only as a human being? Is there any support groups available for these peoples in anywhere and we don't know about it actually? If we know about it, we can also help them to get support from the group which is already have there.
You mean to say transgender community?
Yes, about
Yeah, there are various support groups are available. I mean, the community is becoming more and more visible. There is a community or a collective or group called Orinam, which is a Chennai-based LGBT group. It's not just for trans support; it's for LGBT community as such. You have got Sahodaran, okay, Chennai-based. It's a trans inclusive space. Head office being in Chennai. Yes, that's also one of the community which exists in Chennai, which I am aware of. I was a part of Orinam, which is a collective. We have a good peer support system. I mean, it's very important to have friends from the community, right? I mean, you are in a class, you have friends from your school, friend from your neighbor. The same way I have friends from the community where if I baffle with something, some odd issues, I need to talk to someone. Somebody should be there to help me out in my odd situations. At least to talk with someone, that is something which is very, very important when I am in distress. And yes, that group, Orinam group, was a group. If you just Google, put the name Orinam, Orinam, and you know the meaning of it, Orinam, meaning we all are one in Tamil. So definitely you will find much more resources available for the community members on that.
Thank you.
Yeah.
Anybody else?
There is some comment about treat each person as a human being above all other aspects, treat them with respect and address the medical issues as we would do for any other person. Yeah, that's right. The medical issues. But as I said, that there are unique issues which are there. You may not be aware about it, which you need to have a special knowledge. Like, for example, trans women can have prostate cancer, but they are still women. You need to treat them as a woman. Trans women need prostate biopsy, diagnosis with PSA. Although they are on hormones, they are taking care of hormones, their bodies are different. So that is something which is, as a simple example, which I gave it to you. This could be cancer patient to you, a trans woman could be a cancer patient to you, a prostate cancer patient to you. Yeah, that's what I mean to say it here. Dr. Sairu Philip, eye opener. Thank you. Got to understand perspectives here, though I was blind too. Hope that has helped to you. Bijuji, thank you, ma'am. Okay, for your bold steps towards. All right. Thank you so much. Dr. Sairu Philip, if you can develop a core module that need to be taught in undergraduate curriculum so that they get to know the facts and attitude they ought to know, it would be so helpful. So let's talk about what's happening in undergraduate curriculum, little bit about it. And there are competencies which are present, which are laid by NMC currently. And we did an advocacy. Now the committee needs to formulate and make a change. They need to call up people, ask them. Okay, so that is the committee which needs to set and organize a structure way. It's not just us. So it has to be a vertical approach now. Kavin, one more common statement from public. The idea of LGBT is against the very nature of human existence. How to approach this statement? I wish I could have added few more slides about what is mean by nature and how natural homosexuality is all about. Homosexuality is a natural phenomena, and there are ample tons and thousands of examples about it. It's nature. Nature doesn't discriminate anyone. It's people who we are, people who discriminate each other. Are we on time?
Yes, please. Very much.
Okay. Any more questions?
Okay. Um, so I think we can wind up the session for now. Thank you very much, Dr. Samira, for bringing some light on this topic um, for us, and hopefully this will help us to practice better. Um, and many things, as many of you have told, these all are new aspect to us. So it is definitely going to help us. So thank you once again for taking time to speak to us. So thank you. That's all to say.
Thank
Thank
you,
you.
Dr. Samira. Thank you so much. I believe you are joining us. You were joining us from a different time zone, and your day is not over yet. And
No,
you might be having a very busy day ahead, I suppose. And still, you found out time to interact with us so patiently. You took us through very eye-opening facts, so to say. Thank you so much. And I believe that at least some of our participants would try to learn more about the marginalized communities in coming days because of your insightful talk. So thank you everyone for joining us and making the session interactive. Till the time we meet again in the next session, this is Sri Priya along with Dr. Samira and Dr. Sunil Kumar signing off from the Pali Media's desk. See you in the next session. Till then, everyone, take care. Bye-bye.
thank you. Thank you. Thank you.